Welcome back to the first conversation. It's the manager of the NHI, Ms. Ruth Jaramillo, and Dr. Natalia Rodriquez, who is the general manager of the NHI, here to talk to us a little bit about universal health coverage and the strategic plan as it relates to the access to healthcare in Belize. Good morning, ladies, and welcome to Open Your Eyes. Thank you for joining us.
Thanks for having us again.
Yes, for sure. So tell us a little bit about the strategic plan and where we are now. I know that there have been the opening of new clinics up north, so maybe we can start with that. Do you want to go ahead, Ms. Ruth?
Sure. Just to give you a little background to remind the public that Belize undertook a health reform initiative that sought to look at the different aspects of the health service in the country and identified three pillars of direction. One which was the decentralization of health services. The other one was the strengthening of infrastructure in the delivery of healthcare, and establishing a national fund for the implementation of a universal package of services. That's where NHI derived or was born, the concept of NHI. So Natalia and I have been the stewardships of that program, and we're here to talk about where we are with that and where we want to see it go.
It's been quite a journey in terms of the inception of this particular initiative and where we are at present. Can you share with us what that process has been like and what it has entailed in terms of getting to where we are?
Well, I would just like to, give a little history. We're 15 years old, 16 this year. And initially we started in Southside Belize City, where we started with the 4 PCPs on the south side, BFLA, BMA, BHP, and Matron Roberts. We then, in 2006, we then went south. And that is where we're now in the southern regions. So just recently, in 2015, we expanded to the north. And basically, it's only 2 zones of the 4 zones in the Corozal district.
Okay.
And those zones include the central zone, which is the town, and a few villages around. And then there's the Pachacan area that will catch at least like 4,000, a population of 4,000. What is important from inception, the model in Belize City was a private public mix, an NGO with BFLA. Later on in 2011, I believe, we extended to Mercy Clinic, which is right here.
Yeah.
Mercy Clinic, which is geriatric care, and the only geriatric, basically, PCP in the country. So for us, that is really a project that we continuously keep working on. The fact that with the NCDs, the non-communicable diseases, and the elderly, the cost of the elderly patient multiplies like 3 times to the cost of having the patient to the other PCPs.
Okay.
All right, so that's important in cost to understand. And right now, at present, up in the north, the mix, we try to promote that public-private mix, because what that public-private mix has shown is that it promotes efficiency and quality.
Yes, for sure.
Having the mix, it complements.
Yeah.
Also, initially in Belize City, I always go back to 2001, where at that point, every PCP was competing to be the best PCP. And what has happened during the years, that competition has changed to networking among them, where they exchange their best practices, and all of them have grown to perform at almost the same level. So when you do their assessments, they're in the high 90s.
Yeah.
Matron Roberts, being a public facility, has been one of the lead stars. And normally you usually hear private sector, they outshine public. But in this case, they all, and I have to, because Matron Roberts is doing a very good job, but all the others as well, They're all to par. So we've seen this model work very well. In the southern region, the model is different, where it is only public facilities by the Ministry of Health. So the challenges in the south have been very much different than in the city, which is an urban setting to a rural setting, where at that time in 2006, labs, imaging, and pharmaceuticals have improved, were a challenge as support services. And we have seen, we've struggled with improving those services, but they have improved. So the southern region as well has improved in the last 2 to 3 years. And what was important there was we took the doctors and the administrators from the Matron Roberts Clinic going down south to have that exchange of best practices and say, we're a public facility as well. We have the challenges you have in serving both NHI and non-NHI, in also have to using two systems, the BHIS and the NHI purchasing and planning, yet we are doing so well. And also there were interventions at the level of the audits, right?
Yes.
Afterwards, which Ruth can refer to, but I've just looked at our preliminary results for our audits that we've done south recently, and I'm very pleased with the results because it's a lot of hard work that goes into trying to bring them up to par, but with their effort and ours and with the participation of the Matron Roberts Clinic, they are now coming.
I have a question. How do you dispel the notion? People hear NHI, National Health Insurance. Just the word insurance, most people think, okay, it's not affordable. It's something that I may not be able to access based on either my salary or my present state of financial affairs. How do you guys sell the idea that this is a national initiative where people should be able to access it? I know you mentioned the idea of the public-private partnership. How do you convince people, the average Belizean person, that this is for you?
That's an excellent question, and it's the one that we're actually in the process of discussing at the moment. Health insurance is what it means to be. It's a protection. It's a social protection. And the idea is that we want to ensure that the population of Belize has that assurance and sense of security that when they need health services, they don't need to pay out of pocket at the time when you need that service. Our studies show that even though we have health services in Belize, because NHI is not covering the entire population at this time, there's still a significant amount of persons who have to pay out of pocket for those basic essential services that we all require. So for example, let's take a simple checkup that the doctor may want to require some blood tests or some imaging tests to determine where you are. For the most part, these services still have to be purchased and paid out of pocket. Or let's say you have diabetes and you require the chronic management of that condition over time. If you're a diabetic in this country and you have to pay for some of these medications, it is very costly. But if we as a population see healthcare, universal coverage as a public good and demand of our government to promote universality, and we all contribute to it financially, then what we're doing, as Natalia says, we are risk pooling. With the healthy population is contributing to cover those who are ill. And those who cannot pay, for example, our elderly, who are now retired, they're not financially contributing anymore, or they're very young, who are again not in the working population, but they need protection. But if we all pool our resources, then the value that we get for that amount of money that you invest is actually very beneficial, because it allows us, the purchasing role, to purchase effectively on your behalf. So we ensure that the package of services that you get for your money are of the highest quality and that they meet the standards that they're expected to meet.
How do you, and just piggybacking off that question, I know that social protection strategies in any country, they're normally geared towards a specific kind of faction of the society. How do you ensure that, one, those are the persons who it's catered for, they're the ones accessing it, and for those people who might not necessarily fall in the bracket of being able to be considered as candidates for NHI, how do you ensure that they don't see it as being at a disadvantage because they can't access this kind of healthcare?
Well, the universal coverage does that. It does offer that protection. So it does not discriminate whether you're employed or not. It's a universal coverage. And then that is why we're saying that allows for equity in the delivery of services. So that not because you shouldn't be deterred from accessing services because you cannot afford it. It's the opposite. We want to encourage access because it's already covered for you. And the only way we can achieve that is through a financing mechanism where all of us consciously contribute whatever we can afford based on our ability to pay, whether that means through a taxation mechanism, through contributions as Social Security, through and it's not just one source of financing we're talking about. It has to be a pooling of those resources. Currently, the Ministry of Health, because it's the mandate of the government to provide some level of service, is paying through general revenues for the existing system that we have, whether it's NHI or non-NHI, whether you go to an NHI clinic or you go to another government entity, this is paid by general revenue. We are already paying for it. The difference is that we need to complement that budget to include the working population who can further contribute, whether I mention a further taxation or Social Security contribution, whatever mechanisms we choose are more effective to complement that and then offer universal coverage. And because that is not the case in Belize right now, we don't have NHI countrywide. We're not offering the true universal package countrywide. That is where the inequities are. And there's still barriers to access because of that. And that's something that we are very passionate about, that we need to advocate.
What does it take, either financially or in terms of a concerted effort to move in a specific direction to have NHI become a universal feature in the country?
Well, I would say definitely political will. That is number one. Secondly, the buy-in of all stakeholders, because at the NHIC level, which is our committee, we have representation of the Chamber of Commerce, the trade unions, also the churches, insurance companies. All this representation is at the level of the NHIC. And so now it's to actually go out and do social marketing to these groups to get the buy-in. So that is so important. And what we have done along the way is to include them in dialogue. We have been in sessions over the past week where we have included them in dialogue. So that would be the other step to go. Also, after 15 years, we know what the cost is, which is very important. Right. And in August 2015, the World Bank did an assessment, and the present cost of each member is $136.25 per annum, per year. So it's not thousands of dollars, but it's per member, $136.
Is it as simple as that, though? In terms of an individual being able to come in and say, okay, under my annual coverage, it's $136, but what do I really get access to? Services that are being provided.
That's another good question. The figure that we're quoting here is for primary health care coverage, the first level, a very significant level though. And so we don't want to give the misconception that we're talking primary health care, we're talking of limited packages. To the contrary, we are primary health care, and most of our health incidences can be addressed at the primary care level. In fact, if we focus more on prevention and early detection of things like hypertension or diabetes, and we manage you at the very onset, then this prevents complications that lead to secondary care, specialist care, and tertiary care when you need dialysis, when you need amputations, you go blind. So our program focuses very much on prevention, including screening services for cancer. So yes, the package of services would be defined for the population. So the population would know what they're getting for that value of money. And we can't just look at primary health care and not look at the other components. There has to be a continuum of care, but it could be on a phase approach. So we can see in this phase, we invest this much, we get this package of services. As time goes and we get this right, then we expand that package and so on and so on. It could be done in phases, or it can be done in one step, but then the public would need to know this is what then I would need to contribute to get the spectrum of care, no?
And what is essential is that we have to get the first level right.
Yeah.
By getting the first level right, you will definitely decrease the cost at the tertiary level. Because at present, the cost of the tertiary level is 5 times more than primary health care. I'm talking about the budget for the Ministry of Health. The percentage that goes into that level of care is very high. So when you look at NHI, we manage a budget of 17 million for the 1/3 of the population we're covering right now, and 90%.
17, you said?
17 million, and that covers 1/3 of our population, 120,000 registered members. And what we have to show now is that 90% of that budget goes into primary health care. 4.5% is our administrative cost, which is very small, and we have a very efficient 5-member staff to run this program. Of course, we have been within the Social Security Board as a unit for the past 15 years, so that helps to defray certain administrative costs as well. It's a brother-sister relationship there, right? So that's important. And then, of course, the remaining 5% is reinvested back, tied to the key performance indicators, which Ms. Ruth could probably talk a little about, because it's not only a payment per member, but it's a payment per performance model as well, which I would like her to emphasize on. So this is our budget right now. In the last 10 years, we have been working, I just learned the term, I was calling it containment measures, but I was corrected yesterday by the health worker. Said those are efficiency gains. I said, oh, wonderful. So, but we have really exhausted our efficiency gains, and we're at a point now, definitely health financing for the program must be addressed.
Looking back over the 15 years that the NHI has been in existence, what would you say are some of the lessons learned that are, one, some of your biggest hurdles to overcome, and two, the ones that have been the low-hanging fruit that you've been able to really implement and do it very effectively, that could be the shining star of the whole strategic plan?
I think there have been multiple successes, one of which is the reform pointed out to the concept of separation of roles. And that's important to stress. The separation role determines what each stakeholder is responsible for. It's part of the reform process. So the separation of those roles identify the Ministry of Health as the key regulator of services, and they are the ones, the ministry is the one that determines what are our health priorities, what are the areas that we need to focus on, because they would have the information regarding the demographic profile of our country, what are the diseases that are prevalent in the different regions. For example, we had a presentation yesterday, I don't know if the public is aware, but even among our ethnic groups in Belize, our different ethnic representations, there is a higher risk of certain conditions among different ethnic groups. For example, hypertension and diabetes being more prevalent among the East Indian and the Garifuna population, diabetes in particular among the Creole population. And when we went south, this is a silent killer, something that is not being addressed, but we were very alarmed to see that there is a high level of obesity among the Mayan women population, and this is not highlighted enough. So these are women who are in their 40s, who are morbidly obese because of their stature that's short, but they can't carry that amount of weight, and they're at risk for literally collapsing. And we need to talk about these things. So the ministry is responsible for that role. They're also responsible for establishing the standards, the protocols that guide the management of these conditions. So we are not just prescribing for prescribing's sake. We are following a standard. Then there's the purchasing role, which is our role, NHI. NHI receives the funds on behalf of the government through the ministry and then administrated through Social Security. We are then responsible for contracting or purchasing the services through contracts with a mix of providers, as she explained. The contract holds these providers to certain standards, right? So that is what she's talking about, the key performance indicators. So every year we literally sit with our providers and negotiate what are these indicators, what are they required to do to get to qualify for that performance bonus.
Earlier in the conversation, you ladies identified the Matron Roberts as sort of the beacon and the flagship for the successes of the program. Are they doing anything different that sets them apart? I'm not saying that the others aren't equally as good or aren't getting to that particular standard, but what is it that is being done at Matron Roberts that affords them this particular distinction? I know one can say, well, it is ideally located, albeit on the south side of Belize City. It's in Belize City nonetheless. People are able to access the services readily and what have you. Is that the only factor that you would say has given them an edge over the other facilities?
No, I believe as we mentioned, it is the competition on quality. When there's something about putting results out there, literally out there, and saying, okay, this is Matron Roberts' performance, BMA's performance, BFLA's performance, Integral Healthcare performance, Mercy's performance. And you see the different scores, and that creates a pressure because you're saying, oh my goodness, I'm way below the standard. I need to step up. Now, see, there was a change in the approach to the delivery of services that was not existent in the public service for a long time. Suddenly there's a pride in what you do. And I believe that cultural change, organizational change, has been the major impact. So that the public sector needed to organize itself and work as a team. For far too long within the ministry, there have been too many vertical programs, like maternal child health, like vaccination, like whatever programs, and they work on their own. This time they realize if they continue in that pattern, they would never meet our performance indicators. These have to be done as a team. So suddenly, the health administrator, the clinic administrator, and the head doctor had to come together and create strategies to bring the whole team. That has been the example of Matron Roberts. That leadership that they have taken, that initiative to engage the staff so that they also take pride in their performance. So much so that if we don't go and present ourselves to do their audits, and check the facilities, they're upset that, well, we did so much and you didn't even come and check us. And imagine, before, having an audit used to instill fear and, even resentment to some extent. Now it's encouraged. And I want to again stress that by displaying the same results, the private sector said, oops, Matron Roberts is now ahead. We need to step it up. So that competition based on quality has put everyone on the same level in the South Side.
One of the examples of that team approach was that the Ministry of Health for many years have been striving to encourage pregnant women to come in during the first trimester, that first visit. And everybody go, oh, they can't make it. It was like a 10%, 20% of the pregnant women coming in during that period. We included it as a key performance indicator, and they realized that alone, the MCH program couldn't do it. Alone, the other consultations by the doctors couldn't do it. But for someone to say they're pregnant, they usually come in and do a pregnancy test. So it changed. When the person would come in and do a pregnancy test, whoever was giving the patient that result of a positive pregnancy test automatically filled out the CLAP form and then submitted it to the MCH program, because by doing that, 2-3 weeks after, if that person did not come in, the nurse can go out and do a follow-up visit and bring them in. So by that collaboration between, they are now over 60% of meeting that target, going from 10%. In the South, we've just included that KPI, and the rural area, that's even a bigger challenge, because especially in the deep South, you have all these, it's more mobile clinics going out to catch. And now they have improved from, because they were very low as well, they were even lower than the city, and now they're at over a 40%. So you can see that the work of the team approach works. And I believe that the program has not only showed the team approach, but also the improvement of the quality of care that is also given to the patient.
You mentioned earlier geriatric care with regards to the elderly and their ability to access these either services or treatments, what have you. You also mentioned that the Mercy Clinic is that particular location for the elderly. Can you speak to us a bit more about that?
Mercy addresses the needs of the elderly. Mercy is basically, we're trying to make it a one-stop, where they have an in-house pharmacy as well. They have an in-house phlebotomist. They also do outreach to those elderly who can no longer ambulate or mobilize by wheelchair to the clinic. The thing with Mercy, if you even visit the facility has all the rails, everything that should be in a geriatric facility. So I always say, when we do the facility assessment for Mercy, their assessment is more comprehensive than the PCPs, because they need to meet certain standards specifically to the elderly. And also the patients, the one-on-one with them. In the last few months, we have helped. It was a joint effort between NHI, the program, and the Mercy Clinic, because we were only able to help with a few dollars because the budget isn't. And they had a fundraiser which complemented to improve on their infrastructure. At present, they're serving a population of 1,500. We want to extend that to grow to at least a 2,025 and eventually get them to a full 4,000 population. It has been a little slow, because on the south side, they are still attending to the elderly. There is no policy in place as yet for us to transfer the elderly into the facility. It's all voluntary. And many of them have fallen in love with their doctors and don't want to leave them. Sometimes, of course, it's because of access. But in the case of Mercy, we're gearing to try and get all the elderly to make it more sustainable at one location, because as I mentioned, the cost is a lot more. The care at Mercy is, when it comes to geriatric care, needs training in certain areas. So the staff has been trained in these areas. We are trying this year probably to get a geriatric specialist to come in and trying to improve on those areas. So Mercy has been quite
An experience.
experienced, honestly. And I must say, they've come on board in 2011 and they have met our standards like rather quickly. The infrastructure, also their audits are to par with the other PCPs. So regardless of them serving a very specialized population, they have come right up to level with the other PCPs.
You know, thinking of the culture of going to the doctor in Belize, I know that there's type A who, for any little thing, then go to the doctor. And then you have the persons who, like you mentioned
Like
earlier,
the
who
men.
wait, like the men. And then you have the ones who wait until something really, really drastic has happened. And I know that when it comes to overcrowding in a hospital, it's very difficult to explain to somebody, well, you have to wait because this is more important. And I know that affects the amount of money being pumped into a clinic. How do you consider that when you're, you know, exercising the purchasing and of the healthcare?
And that's a big challenge in terms of waiting periods. That continues to be one of the biggest hurdles for us. Well, it's positive and a negative. Positive because it means that people are accessing the services when they need it.
Yeah.
But a negative also because you have individuals who actually go and maybe unnecessarily.
Yeah.
Some conditions can be managed at home and with a little consultation. And this is where we want to introduce other initiatives like telemedicine, where you have an opportunity to call in your doctor who knows your history and say, Doc, I'm like me. I'll use me as an example. I suffer with chronic migraines. Okay. So I know my routine, but there are times you want to just verify and you don't need to go into a clinic with a crisis, a migraine crisis, sit there for 3 hours to be told you're doing the right thing. A phone call could have addressed that. The provider pulls out your record and say, yes, Ruth, I see you have a history of this. What is the medications you're on right now? Continue with that. If within an hour you don't feel better, then come in. You know, that kind of thing. Is there any new symptoms you're developing? No? Okay, let's go as planned.
Okay.
That kind of would decongest the clinic.
It saves time and money.
Yes,
as well.
it saves time and money, and we have to be proactive in this way. Other people have to go and sit because they're waiting for results, for example. And technically speaking, ideally you want that consultation with the doctor to discuss your results, but there are also ways to address that that is efficient and saves the patient time. So that those who are actually going really and need to be seen are seen at a faster rate. But the public also needs to understand that to deliver quality of services, we have to do a triage, which means that we have to prioritize. There are patients that you cannot ignore, cannot wait. Even though you may have had the number one seat position, if I come in with symptoms, or if I'm a very young baby with high fever, I need to be seen. If I'm a very old person with complaining with chest pain, I need to be seen. So that education is important with our public so they understand their role.
For sure.
Well, are there any final words that you would want to share with us, seeing as though we're at the end of this particular segment?
I would want to just add that every year we do a continued medical education symposium on NCDs, and that this year we will be doing it the second week in June for all our healthcare providers who usually attend. I'm just announcing it publicly so because it has been growing, the participation has been growing over the last 3 years, and we expect a crowd, so we need to keep everybody updated and posted on the date and registration.
And then I would just want to encourage the public to keep asking questions about where we are with the NHI and to encourage the government and all the relevant stakeholders to make that decision, to propose the financing options and have the people decide. Universal health coverage is something that is social protection. It is one of our development goals. And we are already on our ways. If we just invest a little more and encourage everyone to buy into it, then we would achieve universal coverage for all for Belize.
For viewers who may not necessarily know the various locations of the facilities, can you conclude by sharing with that information with us?
Where are the clinics located?
Yeah.
Well, in the south side of Belize, there are 5 clinics. We have the BFLA clinic. They're all in the south side primarily. Then we have the Belize South Side Clinic, which is by the Governor General's house, that area. We have the Universal Healthcare Clinic, which is on Curacao Street. We have the Mercy Clinic, which is on Mercy Lane here. And did I miss another one?
Matron Roberts
Matron
on
Roberts.
Magazine Road. So the BFLA is on the Boulevard, Central American Boulevard, corner Mahogany and the Boulevard, right? Then we have on Regent Street, we have BME, the Southside Clinic, and of course Integral is on Curacao, and what did we miss this?
Cleopatra Way.
No,
No,
that's
Matron
not
Roberts is on Magazine, right?
on the southern districts. You have we're everywhere. So all the main facilities, the Ministry of Health facilities, are NHI
Satellites.
clinics.
Okay.
And each of the main clinics have satellites in different locations. So that can be, if you're not sure, you can call the NHI office and we can give further instructions. We also have a network of pharmacies and labs and imaging centers in Belize City, which we can also provide information on.
Okay. Thank you, ladies, for joining us. We're so grateful for this conversation to give us an update about the universal health coverage. Thank you very much.
Thanks for
Thank you
having us.
too.
So we are going to take a really quick break, and when we come back, we'll be joined by representatives from NHI to talk to us about the upcoming Street Art Festival. Stay tuned.